Change is always difficult, but I like to think about the process as kind of growing pains, and maybe we're growing into something better.
The biggest change I've seen is the move from Hanover to here. I wasn't on the switchboard then, I was in security. I was standing by the emergency room directing traffic for most of the day.
We moved the entire hospital from our old hospital, which was a bit like being a mole in a hole. It was dark, tunnely, and we came here to this bright, beautiful new building with delightful space for patients in their rooms. You look out the windows and you watch the seasons change.
The move took place, which was great. Watching the hospital implode, that was a sad day too. I attended the Mary Hitchcock Memorial Hospital School of Nursing and graduated in 1978, 2 years before it closed. It was a very good school.
One of the biggest changes that I have is moving to Heater Road in Lebanon, New Hampshire. The building, the space is beautiful down here. Patients really love it because we have a big space for them. The parking is really excellent for the patients, and all they have to do is walk in and we're right there for them.
When I first started working as a brand new grad, they sold cigarettes in a vending machine in the lobby of the hospital. And the patients could give the nurse money to go down and put it in the machine. It was the kind where you put the money in the slot and you pull out the knob and the cigarettes fell down. I worked on a cardiac floor and I didn't think the patient should smoke. But they did smoke in their beds. Nurses and doctors smoked at the nurses' station. Doctors smoked pipes, cigarettes, whatever, as they're going around making rounds. So it's very different. You know, we went tobacco-free in 2008. And that was a huge step forward and a really big change in the right direction. So now there's no smoking anywhere on the entire campus. It makes a huge statement to the patients and to our visitors and to the people that work here that we believe that this is an important enough thing that we're making our campus tobacco-free.
We really have our feet in two canoes. For a long time we've been firmly in the fee-for-service canoe, but now there's this other canoe. Risk, accountable care. The two of them are pulling apart very quickly. It's a really uncomfortable place to be. But the challenge is that we remain a tertiary specialty care provider as well. We want to move to risk because this is DH's future. This is part of us providing a sustainable healthcare system with the services it needs and providing great value. But we'll always have our foot in that fee-for-service canoe as well.
When I came to Dartmouth-Hitchcock, I immediately recognized that shared decision-making was a huge part of the care planning for patients, and it impressed me tremendously. And then I later learned that we were really the leaders in the country for shared decision-making, and I think it's just critical that the patient perspective, what the patient wants from their care, is considered. It has to be about what the patient wants.
Patients have always been at the forefront, but I see an even more concerted effort to always keep the patient at the beginning or the focus of your decision making. Even more so, there's emphasis on quality of patient care.
Rehab medicine has changed a lot since I've began working in physical therapy. Doctors are recommending to have physical therapy, occupational therapy more, so fewer patients have to have surgery and not end up having to stay in the hospital for a period of time.
I see changes in food service taking place daily, weekly, monthly. They're forever changing. whether it's getting rid of fried foods, whether it's getting rid of the sugar-sweetened beverages. What I'm seeing now with the customers, they're really asking for a lot more information. They need the nutritional information, the allergy information. And now we're seeing changes. Where is this beef coming from? How local is it? Is it sustainable? Have there been antibiotics added to the chicken?
The Department of Primary Care has grown immensely. Primary care is really focusing on prevention to keep patients out of the emergency room or possibly out of inpatient units.
In a fee-for-service, which is the old paradigm of US healthcare, if you do a test, you get paid for it. When we're moving into our new paradigm of an accountable care organization, when we're pairing much more with our community, where a lot of the care is being based in our community areas rather than up in Lebanon, it's important that we don't do tests that we don't need. We're not going to be paid for them, and we shouldn't be doing them anyway. Our patients shouldn't be paying for things that are done too often, aren't the right test, or an expensive test is performed when a much cheaper test could be.
Is everybody ready for a timeout?
Yes.
Yes.
Involving the timeout process in our day has improved a lot of things. Safety, things that we need, saves a lot of time, and it's actually a great chance for all of us to communicate, and to me that feels good because you don't always feel like you can ask a question or because it's not a good time. That has been a wonderful change.
If I'm a patient, I want some new discovery that came out yesterday to get to me today. We need to be extremely adaptive, extremely ready to learn, adapt, innovate, and bring those things, and that's all change.
We're moving towards one DH, which consolidates all of our outlying clinics into one large system. And from the patient's perspective, I'm sure it has to be better. It's all the same system, and from the patient's side, it's much more seamless than going between systems. I think that's harder for patients.
We work together collaboratively, obviously, with the folks that are in the southern region because the patients are our patients. They're not two different sets of patients. It's one DH. It really does. I think it's working well.
To me, the thing that I think has changed most over the past 10 or 15 years is really putting the patient in the center of the healthcare equation. That you need to understand the data to help guide you towards decisions, but that every individual patient is different. And delivering what we're calling patient-centered care is probably one of the, I think, biggest advances for the patient that we've made over the past number of years.
I'm a cashier and I deal with change every day. You have to give back the right change and make sure the customers give you the right change.
You have to use more quarters, more dimes, even a lot of pennies.
Cost in healthcare has changed. They want the patients to get the best care for, being more efficient, and I like that. And I think it's something that needs to be done.
The infrastructure we've built in this country around healthcare is very expensive. What is going on in healthcare right now is a fundamental shift in how care is financed and how care is provided. And it is a period of time in history when we can either leave people behind or we can bring people together to provide a greater level of consistent health care.
We're saving money. We weren't probably saving as much money before, using whatever we wanted and using all kinds of supplies, which is what we were used to. It's a good change in that aspect in the OR. We don't open as many things. What we do is we open what we know we need, and we make a pile of things we might need, so it just saves money, and that makes everybody happy.
All the time you should be thinking of better ways of doing things, and Lean is a set of tools that has allowed my whole department to think of things in a different way. If you want change to work and to stick, you need to ask everyone, particularly the people who do all this work. They were the ones that came up probably with the most exciting ideas.
I was asked by Dr. George Blake to work with a team from the infusion suite of the Cancer Center. The flow and the somewhat chaotic work environment was a dissatisfier for the patients and the staff as well. They were ready for change. The results which were anticipated were the infusion suite actually increased their capacity, which was good institutionally. The patients felt that they were more attentively cared for and in a safer environment than they had been before, all without any additional resources.
All around us, the same thing's happening. The practices, the theories of bottom-up management, measuring a process, undoing it, and building it up again. And it is going to save money and cost, and it's going to be more effective for the patients.
Technology has changed a lot here, and much of it for the better, in spite of the fact that we may be frustrated with our technology at times. I was the first person to get a computer. It was a Macintosh Lisa. It was a little square box that sat on my desk. And we had little floppy disks that you stuck in there that all the data was on. Now, of course, every provider in here has a computer. Everything has changed.
The MyDH portal, you can be in your jammies at 11:30 at night and send a message to your provider. And then the provider's nurse will answer that, and the next morning you could get up and there you go, you've got your answer, and nobody's had to have a phone conversation. You can request prescriptions, and you can see your appointments. If I've forgotten what time my appointment is for tomorrow, you can look it online.
I think one of the changes here at Dartmouth-Hitchcock that I was able to be a part of, again, was being a credential trainer with EDH, coming back as a super user. I felt like I really made a difference with my colleagues, pulling that together, giving them the support when they were very stressed or frustrated. I felt like all my years here at Dartmouth-Hitchcock really made a huge impact on a lot of my colleagues.
The Connection Center actually is very involved with, we have the new telehealth is coming around the corner, right? So we'll have referral requests that will come in, and our physician sits here at Dartmouth-Hitchcock on the main campus, and then the patient is seen in their local community at their local hospital or whatever, and then they do it all electronically. The patient could be sitting in Seattle, and our doctor could be sitting here in Lebanon and do the consult that way.
Can't do this alone. It's a matter of everyone being a part of this change and helping to improve the patient experience.
Change can be difficult, but I have to say that the new Williamson building is a thrilling and exciting change for us because it's space that we've been wishing for many years, and it is in the perfect location and it is the perfect layout for us as a department.
I think it's important to keep upbeat, keep learning, stimulate your brain, do what you can every day to make the difference.
We have started the process to become a sustainable health system, and we're trying to create the relationships with our other local hospitals, with regional networks, you know, the connection that we have with the Mayo Clinic now, trying to be collaborative in healthcare and not necessarily being individualistic, whether about the patient or about the health system. It's about the broader concern of the healthy nation.
We give the best possible care there is. And there is always room for improvement, and we're always growing and changing because you can never stay the same.
None of you came to be here without facing some challenges and change. I see change for us as a great path towards being a great organization.
I'm inherently impatient. I wish we had done more. Are we on the right track? You bet.